Okay, we have set an impossible task for our facilitators for the breakout sessions to try to encompass the main points that were discussed in just a matter of a few minutes, 3 minutes or so. It's not possible, but they're going to do their best. Just to reiterate that we will be writing up the proceedings of this conference. All of the presenters, facilitators, moderators, and anyone else who wishes will have a chance to contribute to that. And that's the forum in which we will spend much more time on the points and discussion areas covered by the breakout sessions. So today is just sort of a snapshot of the high-level points that are being discussed. And I would suggest that we go in order of who's prepared to speak first. Which facilitator is ready to speak? Okay, Dr. Mazursky, please. 3 minutes.
Okay. Is there a timer so I know? Okay. Okay. I should probably know, well, I was topic 2, which was what can we do to help increase knowledge and access to treatments, the latest treatments with healthcare providers. So we had a terrific discussion. Thank you to everyone who was there. The first thing I would say is in some ways our conversation took a step back and said, well, hold on a minute. First of all, you need access to a healthcare provider. You need a healthcare provider who knows about the latest treatments, and it was very clear that there's lack of knowledge in 2 parts. Healthcare providers lack knowledge about the latest treatments, about diagnosing Alzheimer's, lack of support, lack of resources amongst healthcare providers, and that the onus is on us, researchers probably, to fix that, not to ask patients to educate healthcare providers. The second was lack of knowledge in the community itself and a need to kind of increase knowledge, where to go, what is Alzheimer's, destigmatize it, recognize the dignity of people who are living with the disease. And one great suggestion that I've never heard before was, could we use MyChart as a way to provide electronic resources to people, educate them about Alzheimer's disease, both physicians and patients? I'd never thought of using MyChart. I thought that was terrific. Another thing that came up was research versus clinical care, and in particular that for people who don't have access to good clinical care, sometimes research is filling that gap, and coming into an ADRC is actually a way to get clinical care that they can't otherwise get. That may not be the solution to our problems, but it was interesting to note that that might be a reason why people, when you have a year-long wait time, you can actually get evaluated at an ADRC more quickly. But really what we talked about is accountability, and who's going to be accountable for insisting that healthcare providers and professionals know more and know where to direct people. And this sort of a slight sense of perhaps cynicism that we recognize the problems and we don't know what the solution, we can't get forward enough to make the solutions here. And someone even raised the question of whether physicians should be legally accountable, like malpractice, if they don't have the right knowledge about Alzheimer's disease and referrals. So really a question about how we make healthcare providers accountable. Many other things from members of my group, if you're here. Cost prohibitive, that we talked about the cost of the drug, absolutely, and that it was totally cost prohibitive, and that actually as researchers going out to the community and talking about a treatment that might be inaccessible, ineffective, and very expensive could actually be harmful to communities rather than helpful. Thank you.
Thank you. Matt? So now we'll hear from Matt Gobble, but just a comment about Jessica's group. As a physician, I do not like that malpractice part. So.
Thank you. My breakout group discussed the same topic as Jessica's, and many of the same themes emerged, so my comments will be briefer than hers. Just a few things that came up maybe different from her group, and it was a terrific group. Thank you all for your participation. So we talked about what sorts of things ADRCs could be doing to help educate and inform, and almost all the ADRCs appear to be actively using their already existing programming, whether it's lunches or CMEs. to provide this sort of information directed particularly at CPCs. But two concerns were raised about doing that. One is how to communicate effectively and transparently about a question of efficacy in minoritized communities. That we'd be, in effect, promoting and encouraging perhaps engagement with these treatments, at the same time needing to disclose that we're not really sure they work for them. And so this is a really tough problem, and one that the emphasis was we had to be transparent about that. The second is capacity, and that is if you get out into the community and you get the CPCs informed and engaged, well, what do you do when they can't get PET scans, when they have to wait years to see clinicians of different sorts, et cetera? And so, again, being transparent and clear about what's actually available in terms of resources, at the same time trying to improve the availability of resources, but in the short run, not setting people up to be disappointed with what we inform them about regarding the treatments. So anyway, those are the two major concerns that came up.
Great.
Thanks.
Louisa, okay, please welcome Dr. Uche.
All right, so our group tackled the question of what would make ADRC research participation meaningful for historically minoritized groups. And immediately, it was noted that those reasons are myriad, many. And each community may actually have multiple reasons, and the most salient or important reasons may not be the same in each of those communities. And so it is incumbent on each ADRC to actually study its own community, poll that community, and figure out what those particular reasons are. A couple of them did come out, and fear came out as a reason why people may not want to participate. And fear that struck me, one that was not surprising, the other was a bit surprising. So the surprising one for me was people not actually wanting to be tested to the point that they may know that they are affected by AD or related dementia. And a second fear, which really comes up a bunch as we in academic circles discuss why people don't want to come do our research, is fear of bad outcomes when they actually come onto our institutions, being treated poorly, being in a place that is not culturally humble, not understanding of them and their needs, or understanding that institutions like this have been complicit in prior bad acts like Henrietta Lacks or others. And then the question of how could we better interact was really the uplifting one, is that people wanted us out in the community. Not just doing the research, but actually interacting in meaningful ways, providing education at particular events that are happening in the community, whether it be church or others, and really being seen and visible. Not just the researchers, or in particular, not just the recruiters or the clinical assistants, but really the physicians themselves out in the community being visible as those that work at these institutions. We said much more, but I'm going to take up too much time, so we'll write that up.
All right, who's next? David Johnson. Welcome, David.
So I had the pleasure of working with a really fantastic group, and we were discussing how to work together and raise awareness of new advances and how to promote them. And I think one of the themes that has come out multiple times, but I think deserves just a little bit of more discussion, is about transparency. And it goes along with cultural humility. So first, being transparent about what your research is looking at, what really trying to bring your expertise as researchers to the group, saying this is important. At least it's important to me, and it's important to the scientific community. This is why I'm looking at it. So your expertise is to be transparent about your expertise, but it's also to be transparent that you don't know anything. That you can be have cultural humility and say, I need help from you guys. This is important to me, how do I do that? And to bridge and to build that bridge is an important theme that came out, is it outstrips the individual's ability to just build the bridge themselves. It really takes, at the superordinate level, institutional support. We're asking our young investigators who are, moreover, have tougher, stiffer barriers to tenure than other white professors of similar rank. And we're asking them to build this bridge by themselves and, moreover, have it not count towards their tenure often. And that goes back to this institutional support. So the institution needs to recognize their lack of presence in the communities that they're asking their young investigators to make relevant discoveries in. And this is a circular problem, and it's one that is going to continue to bedevil us until we have a serious conversation about not only universities, but also funding agencies. This requires much more effort and much more recognition by institutions, academia, as its importance. So trust is a multifaceted problem, and it takes many different approaches to resolve that. And that's probably the foundation in which you can actually raise awareness and work together. We had some other wonderful ideas about, if you are asked to do that, how do you do it? Well, you work with community members who know what they're doing already. And I'm getting the hook. Positionality is what I'll leave you with. Make sure it's a we, not a you and an us kind of conversation. Thank you all.
Thank you, David. Monica Willis-Parker.
Okay, we were the second talking group on how can minoritized communities and ADRD research groups work together to raise awareness about new advances in Alzheimer's and promote access to them. We had some very nice suggestions and discussions. How could research teams engage with the community and build trust? One of them, in addition to transparency, included things like visibility of providers, being geographically where the people are and understanding what the community's needs are, being authentic to express and share differences and interests. And most importantly, in all the questions that we asked, there seemed to be a need to develop an effective communication strategy with whatever population you were dealing with. Some of the centers engaged in Texas, they involved promontoras to get engaged and get into the community and sit down and listen. What would working together mean to you? What types of involvement would community members like from ADRD teams? We heard from people who wanted to have more information that they could digest on their own, visual learners, wanted something to read that they could look at and take away from things. We wanted people to have events they wanted people to have events in their community that they could participate in. They also felt that when it came to developing research, the time to involve the community was not so much when you started to need people to participate in the actual studies, but actually the design of the study and to work on things like inclusion and exclusion criteria so that more people would actually be eligible for studies. The other things that they said, think about non-negotiable things and not things that might be nice to have in research. Look at medical procedures and make sure that the procedures that you're going to engage in are well understood by the targeted population, and have informed people, whether it's staff, providers who are delivering the message, to be similarly trained, and that kind of reassurance. The other things, what are some of the ADRD teams doing that's working well? And these things stood out to me. Accountability, timely follow-up, callbacks. A word was used called rapport tracker. Somebody engaged with somebody at the time of an event, somebody called them within a certain amount of time to gauge their interest and to keep them involved. And Also, to continue to provide education about what you're needing, disease processes, that would seem to be a lot. But the other thing, personalized outreach, was taking the time to write a card or a note to say thank you, and in the course of participating in research, to say thank you and acknowledge somebody's efforts to collaborate with you. Something that came up that to help other people understand procedures was the idea of having community studios where participants could talk about their experience and bring those people along to the different visits. There are other things, but the most important things that I heard were being authentic, being transparent, being accountable, being well-trained, and creating visibility so that people were accountable for what they did. So somebody's going to call you back, a picture, a telephone number, and a name of who's going to be definitive about contacting you. And I think those are the biggest highlights from our team. We were all across the nation. Thank you all for participating.
We have Doug Petty.
Well, Dr. Mars, you messed us up. We already had a plan. We were going to let our scribes do this, but I'm up here now. All right. So I just wanted to let you know that we had the best distinguishable breakout session of all. Even to a point to where we had a $10 million prize on the line that we decided that we would come back in the spirit of NIL, name, image, and likeness, to say that we could become a task force with that dollar amount and could answer all of the questions that everyone actually has. So the goal was to see how can we enhance participation among minority groups, emphasize the importance of cultural intelligence, the importance of investigators being sensitive to the real needs of where individuals are. Something more is to be present not in a seasonal way, but to be present all of the time, to build yourself into the community, to really embed yourself in the community, even if it means things such as volunteering for activities that have absolutely nothing to do with what the intended goal of research project is. Vetting individuals, dealing with credibility transfer. Credibility transfer is that someone who already is credible can give you credibility capital by your connecting with them, and it makes it so valuable. The other thing is to be able to respond quickly to any of the challenges that are there. And so I use a personal example, and that was you make your connection and then you build out. I had said that my wife and I never went on a date. I just said, you're supposed to be my wife. And that it meant she looked at me like I had multiple heads. But after 9 months, she said yes, and 60 days later, we were married. And so what that meant is the connection is made, and you build out the plan afterwards. If we focus on making the connection rather than trying to sell the bill of goods, then that will enhance the prospect of where everything actually goes. Now you can see why you should have been in that session.
Beverly Berry from the Alzheimer Association.
It's a tough act to follow, but we had an amazing group as well. Our topic was what can ADRD research centers do to support historically minoritized communities? And so some of the common things that others have already mentioned as well, but one of the first things was to know your community. And that if you don't know your community, then you need to learn it. And you do that by connecting with key members of the community, key leaders of the community, to understand some of the dynamics and history that's going on within that community. The other thing is to be present and consistent. There's nothing more frustrating than when you have researchers or organizations that bring in a new shiny program and you get the community all excited and then you don't see them anymore. So building consistency over a period of time. So, having a plan for that, whether it's quarterly, whether it's monthly, but continued engagement in community. The other thing is once you learn about your community, you learn about the cultural nuances, all of the things that the community need in order to be able to have the support and resources needed, that you also invest and take the time to make sure that we have translators, to make sure that materials are translated in language, that you're taking in all of the cultural relevance and everything that makes up that community to show up for the particular research that we're wanting them to participate in. And then also build research that is centered around community. So making sure that the community is at the heart of the research and that you're not looking at your methods and protocol and all of those things, that you're really looking to embed the community into what you're doing, and then everything else follows.
Krista Mulder from the Knight ADRC.
So I guess I'm the last one. I won't take too long here, too. I want to thank my group and also thank my group being willing. We were sharing it with the online community that was still on Zoom, so happy to thank them for being open and sharing their comments, and for the Zoom folks for chiming in as well. So most of the things that we talked about were already covered. A couple key things that we touched on that maybe weren't already covered by the other wonderful facilitators were that this is really a team commitment, that we have our ORCORs and our outreach community, but we need our clinicians to be present, our other cores to be present. This is really everyone needs to be visible, and this is a team commitment to make this work and be out there. We also emphasized, especially the pandemic has taught all of us, that we need to be willing to pivot, but pivot also when we're listening to our community members and we ask them what they want, and we're already doing one thing, that we need to be flexible. We might need to change because our demands and interests of the community are changing. We also talked about fostering a sense of value among our participants. We always, I know, try to be careful to say participant and never subject, but to even go beyond that and maybe say community scientists, and to really have this bi-directional communication about what our participants are doing and how we're learning from them, and how all of our participants are really helping and contributing to science. And I wanted to end on one thing, talking about what the ADRCs can offer our communities and our partners out there is, people think about how they want to reduce risk and live well, but one of the things that we're really hoping is that we can give them a sense of hope. We're all trying to build something better here too, and that we want to share this sense of hope for our research and for what we're doing for Alzheimer's disease and for all of our communities that we're partnering with.